Welcome to Leading Organizations That Matter, a podcast about how we find meaning, purpose, and impact in our work. I'm your host, Ray Spadoni, and today's topic is healing the healers. This problem is not a new one, but it is growing and it is gaining more attention. The COVID-19 pandemic may have exacerbated it, but it was there before it, and it's still here now. The problem? Physician burnout. Today, I'm pleased to interview Dr. Erin Sullivan. Dr. Sullivan is an associate professor of healthcare management at the Sawyer Business School at Suffolk University, and she holds a faculty appointment in the Department of Global Health and Social Medicine and the Center for Primary Care at Harvard Medical School. Professor Sullivan conducts research focusing on the status and importance of primary care in the U.S. healthcare system. Over the past several years, she has conducted primary care-focused research related to three important topics. First, burnout mechanisms, reduction, and elimination. Second, the lessons learned from the impact of COVID-19 on healthcare providers. And third, the role of physician leadership in more effectively guiding healthcare systems. Professor Sullivan holds a Bachelor of Arts from Wellesley College and a PhD in Business Studies from Trinity College in Dublin. Welcome to the podcast, Erin. Thank you for being a guest here.
Thanks for having me, Ray. Excited to be here.
Awesome. Important topic today. We are discussing physician burnout, a term that seems pretty self-explanatory, but I bet you have a more specific definition. Would you mind setting our stage today by defining the term for us?
Sure, I'm happy to. So Christina Maslach has done a lot of the work, the definitional work around burnout that has been adopted and used in healthcare and in a lot of healthcare studies that you will see written about healthcare worker burnout. Since it's most commonly used and accepted, it tends to be the one we use, and it has three distinct components. Number one is emotional exhaustion. That is feeling drained, fatigued, and emotionally overextended by one's work. Number two is depersonalization, where healthcare workers might develop negative, detached, or cynical attitudes towards their clients, patients, or coworkers. And number three is reduced personal accomplishment, a sense of inefficiency a sense of inefficiency and lack of achievement at work. And individuals feel like they're not making a meaningful impact or they can't be competent at work with this last one. And I think that's important. Now, while Christina Maslach's definition is the most accepted and used, I do want to say a couple of things about the definition of burnout because I think we've found some interesting things related to that recently. During COVID-19, there was a lot of work done on burnout. And we had the opportunity to actually ask people in the national COVID-19 survey, how do you define burnout? Um, to see what burnout actually meant to healthcare workers. And what was really interesting is that in our study, 78% of the definitions and the answers we got to that question, how you define burnout, didn't match Maslach's definition.
Hmm.
They couldn't neatly be categorized as emotional exhaustion, depersonalization, or lack of accomplishment, which tells us that this standard definition and some of the standard metrics might be missing important burnout dimensions, including what causes burnout, what might be wrong with health systems contributing to healthcare worker burnout, um, mental and physical challenges, as well as varied feelings and life issues. So there is a question in one of the burnout measures called the mini Z that asks people using your own definition of burnout, how burned out are you? Because one of the beliefs from the scientists that have been studying this is if someone perceives they're burned out, that's all that matters. So
Hmm.
Maslach has a definition we use. People have their own definition that they might be using, and I think it's worth acknowledging that and acknowledging that some of the tools actually use that personal definition to measure. So I'll stop there, but
Okay.
feel free to follow up.
Well, that makes sense, this notion of self-identification. but it does seem to me to open the door to a great deal of variability in definition, and that, your results are always going to be subject to some interpretation. But just quickly, and you mentioned the pandemic. I want to come to the pandemic because I think that put a bright spotlight on this issue. But I suspect it wasn't the beginning of this as a challenge for us. But let me just back up a bit. I started off by talking about physician burnout. You mentioned healthcare worker burnout. Could you differentiate for us here? I mean, I think in terms of physicians, but of course there are many other key provider categories in the mix here. Could you talk about a little bit about that, Erin?
Sure, and thanks for that for noticing that. So yes, physician burnout is an issue, but I think what we have learned and seen in the data is this isn't just physicians anymore. This is not a uniquely physician problem. This, as I think of it, this is a healthcare problem. We have studies, again, a lot of them are coming from COVID when we had people who were willing to take surveys because there wasn't a lot going on in the world. And, a lot of people were actually looking for outlets, I think, for what they were feeling. But we now have the data that show it is everyone across healthcare, from CEOs, CFOs, COOs, to physicians, to nurses, to medical assistants, to patient service reps who are answering phones, to the environmental services staff. This is a across the board phenomenon within healthcare. We have data on lots of different groups that work in healthcare that have reported burnout.
Okay, wow. So it's broad based. It's not specific tracks per se or types, categories of worker. It is very, very broad based, it sounds like.
It's very broad based, and we do have one study in which we saw that it looks a little bit different in different roles. Um, but it is, as a phenomenon, burnout has affected everyone in healthcare. How it might look, how a nurse might experience it might be different from how a physician experiences it, but everyone is experiencing burnout.
Are you confident, based on what you've seen and based on your work, that this really is a healthcare industry specific phenomenon and not something that's more societal, cultural, something going on at a broader, kind of anthropological level, or is this the healthcare industry we're talking about?
So I just study healthcare, right? So for me, this is a major issue within healthcare. I think it's quite possible that this is existing in different pockets of society or other industries. I've done a little bit of work with a healthcare system that focuses on parental wellness. And while we've done it focus on parental wellness within a healthcare system, I could actually imagine parents in other industries wherever they're working might have been experiencing burnout, particularly during COVID, um, with kids at home and schools shut down, and that might have caused additional burnout for parents. So I do think this is probably a phenomenon that is crossing industries and different pieces of society. But for me, most of my research is in healthcare, and I see this as a big problem in healthcare.
Gotcha. Okay. So I broadened it out to the larger societal culture. Let's talk intergalactic. No, I'm kidding. Um, we're gonna hone in on healthcare. That's what we aim for on the podcast. That's your area of expertise. What does your research suggest are the primary causes? And are there aspects of work environments that seem to contribute more than others?
Yeah, that's a great question. And my research that I have done on in this space for the last 6 to 7 years has actually been informed by even earlier research that was done in this space over 10 years ago. One of the seminal studies actually showed that time pressure within the clinical setting, as well as what we call the three C's, chaos, culture, and control, all contribute to burnout and our work environment factors. So, a system with excessive work, so high workloads, and chaotic environments without suitable controls or attention to aligned values is associated with lower quality of care and burnout. And that comes from one of the early studies. Um, and healthcare workers in systems with high workloads, lots of chaos, they have less favorable experiences, they report more errors, and they often have a higher desire to leave. So I really think from an environmental lens, I think around workload, I think about control, or that sometimes shows up as lack of autonomy. And I think about individual sense of purpose and meaning in the job. I think that's important. And we've also seen that actually as a protective factor against burnout. The other thing that I like to think about in terms of the work environment factors is the National Academy for Science, Engineering, and Medicine have a great framework around burnout that I like to use and teach that divides burnout into individual level factors and system level factors, right? So there are some individual level factors that contribute, such as personality traits, personal values, ethics, individual ability to cope and coping mechanisms. Those are all individual level factors that play a role. But then there are these system factors or these work environment factors that come in. And that's where I think organizations have some levers to pull potentially. I think a lot about what a rural CEO explained to me 5 or 6 years ago, which is that yoga does not fix a call schedule that is burning out your physicians. Like that's a structural change that needs to be made by the people in charge of the call schedule. And free pizza is not going to make people feel valued. And that's one of the things we heard a lot. Like, stop sending us free pizza during COVID. That's not making us feel valued. What makes us feel valued is actually expressions of thanks or our leaders showing up in the ICU and talking to us and seeing what's going on. That's going to make us feel valued more than, another free pizza.
Well, my plan for this podcast was to develop an inventory of solutions. So yoga and pizza are out. I take
Yep.
it. Yeah,
Yep.
darn. That's too bad
Sorry.
because I was going to lead with pizza. No, workload. So let's talk a little bit about the consequence. What's the implication of the burnout? Are you seeing that people are leaving the profession? They're rethinking whether to come into the profession, and then this becomes somewhat of a self-fulfilling prophecy because then you have shortages. The providers who are in the system have to work that much harder, and does this then send us into a cycle that's heading straight downward?
I mean, we are having issues with recruitment and retention across healthcare since COVID. I don't think that has shifted that much. So for those who are, let's talk about the current workforce before we talk about pipeline. I think for current workforce, we continue to see almost a revolving door in terms of retaining your nursing staff, your administrative staff, your physicians. I think that remains a problem to have attractive, manageable jobs with a manageable workload for healthcare workers. That I think has not shifted dramatically. Um, and so that's an issue because we need people currently practicing medicine. And I think one of the things we've seen that I'm trying to get some data around is fractional quitting, which during COVID, we heard a lot about early retirements and people retiring early and deciding medicine wasn't for them and going to do something else. There's something that has since happened that I'm, like I said, trying to get data around, which is how many physicians are still practicing medicine but might have decreased the amount of medicine they're practicing, right? How many physicians have gone from seeing patients 4 days a week to 3? Because that causes access issues for patients. And that is still having a doctor who's still practicing, but is practicing less, and figuring out how to track that and track the numbers for that, I think is interesting because I think that fractional quitting is contributing to some of the access issues patients are experiencing, and we haven't quite figured out how to measure and account for that in our current workforce.
Okay. Well, this might be a good time to go to the timeline question, the trend line, you know, piece
Yep.
of this, which I think burnout came to the fore. We heard a lot about it during COVID. I
Yep.
think we all observed how much pressure was bedside and on those who are caring for patients in ambulatory practices and so forth. I was leading an organization at the time, and we certainly saw the impact on our nursing staff of all this. Um, and so I guess the question is, was COVID the culprit? Did that put a spotlight on it? What was happening before the pandemic hit? What happened during the pandemic? And then, what's been happening since?
Great question. And I think if we like rewind the tape to 2018, 2019, so to speak, pre-COVID, I'll tell you what I was doing, which was working in primary care specifically and working on a collaborative to address burnout across the city of Boston and several of the major health systems, specifically in primary care. So pre-COVID, we are actually working hard to decrease burnout in primary care, which was one of the specialties pre-COVID that was experiencing high levels of burnout. At the time, I believe to be a primary care physician and do everything that you need to do as a primary care physician, it would take you 21.7 hours of working. There's only 24 hours in a day, but to be a primary care physician pre-COVID, it was 21.7 hours of work if you did everything you're supposed to do. And so we were working really hard to decrease burnout across primary care practices in the city of Boston. And we actually found in that collaborative that strengthening team structure within practices and combining that with reducing administrative waste in the practice, actually, we were getting great results in reducing burnout across primary care teams. And that was really exciting. And the health systems were bought in and investing resources in this. And then along comes COVID, and everything that we were doing in that space stops because we have a pandemic. Um, so what I would say is pre-pandemic, we knew it was a problem and we were working on it. Then COVID happens and we have a whole different phenomenon where I think we initially saw in the healthcare workforce like incredible feelings of meaning and purpose in fighting the pandemic. And the first, say, 9 months of the pandemic, everyone sort of, I trained for this. I know how to care for patients in a situation like this, and people are feeling meaning and purpose. And we saw this in national COVID data across the country that I had the privilege of analyzing those first 6 months. Lots of meaning and purpose, people feeling like they know how to do the job they signed up to do. And then I think what we start to see after that, initial meaning and purpose spike, so to speak, is skyrocketing burnout. We start to see burnout skyrocketing in the emergency department, in
Mm.
the ICU. It's also in primary care. Primary care wasn't in the headlines, but I'll tell you, they were on the front lines dealing with anxious patients, sending portal messages and making appointments to talk about what happens if they get COVID. And they were experiencing it too. But we see a lot of headline burnout in the emergency room in the ICU. And I think we see a lot of more conversation about it because it's moved out of the places I was reading about it, like medical and healthcare journals, and it's moved into the front page of the Boston Globe and the New York Times, and everyone's talking about burnout and healthcare and what's happening in COVID. So I think COVID was a little bit of a unique situation that accelerated the experience of burnouts in some specialties and then also put a spotlight on what was happening and on a complex system that is not actually always easy as a work environment for healthcare workers. It's a complex system. It's a work environment that is sometimes characterized by high workload, chaos, some cultural issues, and it's not where people always want to work, and it's they're feeling burned out.
Mhm. Well, I think one of the challenges, and I'm curious to know if this has been your experience or you've seen this, but one of the challenges when you look at something as being an industry phenomenon is that it takes the pressure off of individual organizations when an individual organization can think. And it's not that they're trying to skirt the responsibility, it's just that it can feel bigger than them. They can say, well, this is happening across the country. This is within an entire professional track. So what can we do? What can we do? But I'm wondering what some organizations actually have been able to do to support the well-being of their employees, of their providers. Are there some solutions out there that are gaining traction? And then what does the data show about some of that?
Yeah, I think that's a great question, Ray. And I think one of the things I've started thinking about fundamentally that's been a little bit of a shift in how I think about this is people are talking about burnout, people are talking about clinician well-being. And I do think, especially as you think across industries and beyond healthcare and how this is playing out potentially in other places, um, I think it fundamentally comes down to at the organizational level for people who are leading organizations, how do you create environments where people can thrive, where people can show up every day and do their best work and thrive and go home and live their life? Because I think that's what people want to do. So for me, maybe it's about burnout, maybe it's about well-being, but I think if I was an organizational leader, I'd very much be thinking, how do I create a workplace and an environment where people can thrive so that that's that's how my organization feels to people when they show up to do their job. Um, Specifically, strategies that have worked, what we have seen work is workflow redesign. So redesigning processes in clinics and inpatient units, communication improvements between within teams and different provider groups, um, quality improvement initiatives that have worked to share the care among different members on teams have helped reduce burnout, right? A primary care physician, I was saying 21.7 hours pre-pandemic. That number is actually now up to 27.8 hours post-pandemic of all the
Wow.
work a primary care physician would need to do. And
Mm.
a lot of my research has been in primary care. So how do you share the care across the team that's supporting you in clinic? That can reduce your burnout as a primary care physician. That can also improve your satisfaction as a primary care clinician. If you can come into your appointment with a patient and really focus on those things you're uniquely qualified to do and that you train to do, um, that improves your satisfaction as a provider and that keeps you in practice longer. Um, the I was asked recently what one thing would I do to reduce burnout if I was, in a clinical setting or in a healthcare setting. And one of the things I think is interesting to think about is can you re-engineer the beginning and the end of the workday so that people can manage that home life interface, reduce the chaos, reduce the time pressure, and feel a sense of control as they come into their day in the morning and exit their day in the afternoon. Do they have time to do that? I actually talked with a practice on a completely different, unrelated study, but they were doing a really interesting thing in their design where they were, and this is primary care again, but they were giving their primary care clinicians a 30-minute block that they could drop in their day in their schedule where they needed it. And it was like a just get it done time. Like maybe that was 30 minutes they needed to call patients back that day. Maybe it was 30 minutes they needed to meet with their advanced practice provider that they work with or their medical assistant. But they were giving people just 30-minute block. They could decide where it goes, and it was helping them to just manage some of the things they needed to get done. So that's like another really, that's a concrete suggestion. I don't have data around this last one of re-engineering the beginning of the day and the end of the day, but I think it helps with that work home interface.
Well, that's fascinating. That makes me think about the fact that there's probably a generational shift that continues to take place where there was a time probably in work life where there was a very significant partition. I think physicians experience this. You were home
Mhm,
or you were at work, and that was it.
mhm.
And then we moved to a phase where we were all about finding more balance. And you're suggesting now that this is really about helping to facilitate the transition by virtue of having a managed interface between the two former partitions. I mean, they still need to be somewhat partitioned, obviously, but this is more than just balance. This is actually helping folks as they move in and out of these different components to their lives.
Yeah, I mean, I think it's sort of like that 30 minutes to reduce the chaos, or if you've had a really chaotic day, to have that sort of transitional space to wrap up a few things and to feel like you're in control, right? I mean, just to sort of ramp up or ramp down and like work on those chaos and control levers that you might be feeling so you can go home or enter into the day and be like, okay, I'm on top of the next 6 patients I'm going to see this morning because I had 30 minutes, or I had 30 minutes to call back people who needed to hear from me about lab results from the last 2 days. I think it's giving people some level of control to manage what they might see as high workload or chaos.
Mhm. Let's maybe shift a bit from what can individual organizations or practices do to something that's a notch above that, societal, maybe from a policy perspective. Are there changes that are being looked at or that are likely that could potentially impact this issue? Again, some of it may be how the professions are preparing and developing the next generation of folks. Some of it may be the payment mechanisms and the regulatory environment. Some of it may just be a broader policy. Like, what is happening from a top-down perspective that suggests that people are recognizing that this is a problem and that we ought to do something about it top down?
Oh, goodness gracious. That's a great question. I think, okay, so from a top-down perspective, I'm not going to give you a solution, but I'm going to explain to you more what I think is part of the problem that we haven't talked about, if that's okay.
Yeah.
Um, I think what really ramped up during COVID-19 and what continues to be significant in healthcare is the enormous financial pressure that are on these health systems and that are on organizations. And it was intense in COVID. And I feel like when I talk to leaders, the intensity of the financial pressure has not let up. And I think we've seen increased consolidation of physician practices into major health systems. Um, and that's also complex for frontline providers when they get absorbed into other systems and I think start to feel potentially a lack of autonomy and a lack of control in their practice. But I think the external environment, the pressures in healthcare around payment and policy are huge. And I think some of what's happening in that space is creating some of the things internally in organizations that are leading to frontline worker burnout that are impacting people at the individual level. So that's one of the external environmental forces that I see as having a part in what's happening. I'm not a policy person, so I don't have a solution for you, but that's absolutely one of the things that I know. We have a whole study that we did on burned out leaders, and that's one of the things that keeps them up at night. They actually love coming to work. A lot of these healthcare leaders I talk to and working with the humans at their job and making people better and getting barriers out of people's way so they can deliver better care to patients. What's keeping them up at night and what they can't always solve is some of these bigger environmental pressures. Um, so that's one of the top down factors. I
Mhm.
think what gives me a little bit of hope from the external environment right now is correctly harnessed. How do we use AI in this space? I um, have a couple of studies in pilot or at the starting line phase around using AI. And I think what I'm hearing from a lot of the clinicians I do work with on a regular basis is how the incorporation of AI scribes into clinical practice is giving, in particular, some of my primary care physician colleagues some of the joy back in primary care.
Wow.
Because, yeah, yeah, I think that's one of the causes for hope is can we use this new technology to give physicians more time with patients? Because right now, anecdotally, what I'm hearing from my colleagues is instead of sitting behind a computer, which they have been complaining about almost since the advent of medical electronic medical records and talking to a patient, they can now walk into an exam room, put down their phone that has their AI scribe technology on it, hit play, and have a conversation with a patient for 30 minutes.
Mm.
And that's actually what they went to medical school to do, is to have a conversation with a patient, to diagnose and treat what brought them in that day. And for primary care in particular, to have a conversation that's going to build a relationship with a patient over time so they can care for them. And so I think that's one of the really exciting things. And then not only is that returning some of the satisfaction and joy to physicians, but that AI scribe is drafting the note for the physician. So um, they are not spending as much time after hours working on those notes. They're editing the notes. The notes need to be revised and edited because they're not perfect. AI is not perfect, but it's saving them a lot of time
Mhm.
in that medical record and in doing a task that was historically taking a lot of pajama time, which is after 5 p.m. and before 9 a.m.
Interesting. Some interesting points, Aaron. Just in terms of the consolidation, I've been working with a number of organizations that are, in various stages of evaluation or implementation
Yep.
of this. And it's, generally speaking, it's financially driven. It's how do we
Mhm.
reduce unit cost? And there are market factors and there are other strategic reasons, but generally speaking, it's about the economics and it's about trying to lower cost structure.
Yep.
And this means streamlining, this means centralizing functionality, it means, homogenizing workflows and so forth.
Yep.
The trick is how do you preserve and enhance clinical autonomy and decision making? And that has, that has proven to be very difficult. On the AI front, I mean, I think I had an opportunity to do a podcast on AI. It's the Wild West. We're at the very beginning. There's a lot of upside. There are some concerns and some
Yep.
potential downsides. So we have to see how this plays out, and we have to make sure we manage it well, and and contend with the ethical considerations and so forth. I'm fascinated by the idea that AI can allow for, as you described, physicians to do the kind of things they would rather be doing and let AI and, technology handle all the rest.
Yep.
I hope, not to be pessimistic, but I hope it doesn't become in some settings a way of uh, enhancing productivity so that more patients can be in the throughput and we can lower our cost of goods sold and we don't need as many physicians because we've got the robots that'll handle this. And it's like, I mean, I guess any technology, any solution can be, used for good, or
Yep.
it can be, used in the other direction.
Yep. No, 100% agree. And for what I've heard about AI scribes being hugely helpful, I've had equally as many conversations, Ray, about the mistakes and hallucinations AI is having, some of the
Mm.
ethical concerns we have about AI in medicine, and also, in particular, clinicians saying, I hope that the people upstairs don't decide this is the way to get me to see 5 more patients a day,
Yep.
right? This
Yep.
isn't used for productivity. And I think, I was on a panel not long ago where I said one of the things that I worry about with AI and use of AI in healthcare is taking more humanness out of the system.
Mhm.
Healthcare has been a very human industry, human facing industry, caring for others, and taking those humans out of the system. I think there's something that we would lose, that we are not even sure what it is until it's gone, right? It's almost like oxygen. You don't know it's gone until it's not in a room anymore.
Mm.
And I worry about taking the humans out of the system. And I think, thinking about humans, one of the other things we've started to see around data for some of the interventions with burnout is peer coaching interventions and interventions that are connecting people back to each other post COVID has been helpful. And so thinking about that and thinking about the power of technology to remove humans is food for thought. How do we keep the humans doing those important jobs and the jobs where we need them? And how do we use technology um, to the benefit of humans so they can do their jobs even better?
Here, here. I mean, you mentioned earlier meaning and purpose and,
Yeah.
connection and community as drivers of sense of meaning and purpose is, I think, a pretty well documented and, as workers ourselves in various environments, the more disconnected we get, the harder it is to feel as though the work we're doing is contributing and valuable.
Yep.
So, yeah. So, I mean, AI ultimately we'll find out. It's either part of the solution or it's just the next big problem, or maybe some elements of both. But we'll have to see. Erin, let's talk a little bit about your work and what you're doing and what's on the horizon for you in terms of research. I guess thinking about the work you're doing,
Mhm.
what makes you more concerned about burnout and what helps you to feel more optimistic?
That's a great question. So I think in the last 2 months, AI has done both, right? And I just talked about AI, but I think AI makes me concerned for all the reasons we just talked about, and it makes me optimistic because I'm seeing clinicians saying, "Oh my gosh, I can sit and talk to a patient, and that's what I went to med school for," right? And I think that helps us keep physicians in practice specifically because that's why they went to med school. They went to med school to care for people. They didn't go to med school to do excessive documentation and sit behind computer screens and work 27.8 hours, which you can't do in any given day, right? That's not what they went to school to do. So I think that's a fascinating space to keep watching. I think thinking about we know burnout's a problem. We have plenty of data. We have so much data about what a problem burnout is in this industry. What we have less data on are solutions that scale. And I think that's exciting to think about and explore and identify more solutions that more organizations and systems can adopt. I think that's where the research agenda for this problem needs to go. Um, so I think a lot about that. I also continue to think about this leader burnout issue and what does it mean? Because generally, specifically in rural America, which is where I've done some of the rural leader burnout work, as I call it, if you lose a hospital leader, um, your organization is more likely to fail. So it's really important to retain leaders in rural America in critical access hospitals. And so, how do we do that? Because it's directly tied to the success of the hospital, and we know that from the data. So I think that's interesting to think about moving forward. And I also think more broadly about some of the pieces of integrating healthcare and other sectors at the community level to care for populations is interesting. To the continuing question of collaboration and caring at the local level for communities, and how do you do that, and how do you train leaders to do that is something I'm sort of starting to think about doing some work with a few organizations. And so stay tuned on that.
Great. Well, the leader turnover, I mean, I've got that on my list of potential future podcast topics to discuss, but I've certainly seen in the clients where I'm working is it seems as though there's a higher degree of churn, is that folks are coming into and out of high level jobs much more quickly than in the past for a
Mhm.
variety of reasons. And
Yep.
it's for a variety of reasons, but it's for the organizations. I mean, we can talk about the impact on people, but certainly from the organizational perspective, it's expensive, it's disruptive, and it hampers forward motion. It
Yeah.
prevents longer term plans to take root and become reality when
Mhm.
you have to pause to bring in new leaders. And that is probably a good topic for a future discussion.
Yeah, I mean the seed for why I even went down that path was a colleague of mine who was working in Colorado at the time saw 2/3 turnover in rural leaders uh, within the year or two at the end of the pandemic. So not in the thick of it. It's almost like a hypothesis we had is did people hang on until COVID was under control and then they were burned out and they left. But they saw really high numbers of leader turnover post pandemic, and we saw a number of institutions here in Boston actually turn over in a similar time frame, and so that got me interested in thinking about leader turnover. Also, because I had read all these comments from the healthcare workforce across the country, like over 50,000 comments, open ended. Is there anything else you'd like to tell us? And some people want to tell you an entire book of things. But the amount of anger and vitriol that workers had for the administrators, for the leaders of the organization, also made me think about, I wonder what's happening with this group, because would you want to be on the receiving end of this and be staying in this job? Um, so that led us down a path to look at the leader turnover and the burnout. And I will say, I think our first phase of our rural leader burnout study showed that the leaders were actually more burned out than physicians
Wow.
and more burned out than the comparable leader group that we could find in healthcare, which would be chiefs and chairs of divisions and departments. And they also had a higher intent to leave in the next 2 years than physicians. Their ability to think about where else they were going to go or what else they were going to do, um, which we call intent to leave, like what's the chance you're going to leave your organization in the next 2 years, was very high.
Mhm. Well, that might just be a good place to end the conversation, Aaron, because a fair bit of what I cover on the podcast and in my own consulting and coaching practice relates to emerging leaders, the next generation of leaders. I know that's a big focus for you and as a professor in a graduate program, but I have a number of topics lined up specifically on that, and I may circle back and want to have another conversation with you if you'd be willing. But I think this is, given the target audience here and given the work that I do, this is a sweet spot topic for sure.
100%. And thank you for having me and thank you for the conversation. And I'm happy to talk about leaders and healthcare anytime.
Awesome. So if folks would love to learn a little bit more about you and your work, how best to find you?
The best place to find me is on LinkedIn. And my profile name is very specific because there's more than one Erin Sullivan in the world. It's Erin E. Sullivan, PhD on LinkedIn.
Erin E. Sullivan, PhD is your
Mhm.
LinkedIn. That's the best place to find you. Fantastic. Again, thanks so much, Aaron.
You're welcome. Thanks, Ray.
Thanks for listening. Leaving a positive review and letting others know about this podcast will help a great deal. My mission is to help empower organizations that matter by supporting those who lead them. I offer coaching, mentoring, and consulting services. You can learn more about me at rayspadoni.com.